Bismillah ar-Rahman ar-Rahim. Alhamdulillahi Rabbil Alameen. My dear students, my dear friends, my colleagues, and those who are appearing in any membership examinations or fellowship examination in Pakistan and the other postgraduate examinations in United Kingdom and also the USMLE examination or STEPS examination part 2, appearing in part 2, and this is important for them. I already said I am actually following infectiology, the infection and disease. Today I want to discuss Mycoplasma pneumonae. Myself is Professor Sayyid Ali Haider. I am honorary global professor of medicine without any fame, name or economics. Now, why are mycoplasmas? Mycoplasma is a genus of bacteria that, like the other members of the class Mycoplasma, important thing is there is a lack of cell wall around their cell membranes. Lack of cell wall around their cell membranes. That is why they are very near to the other family fungus. And tetraglycan is absent, which is an essential part of the cell membrane. This characteristic makes them naturally resistant to the antibiotics that target cell wall synthesis. They can be parasitic or they may be saprotrophic, that they are present in the sand and environment. Now this is the structure. The cell wall are incomplete. They are branching filaments-like type of organisms which you see as a gram-negative organisms. They are not staining with the gram stain, but they are not purple colored or what is called as the indigo color. It is not like this. So they are negative organism, gram-negative bacillus. It is bacteria, not a fungus. Same one as the pneumocystis jirovecii. A very long discussion has been done since 20-30 years. It is a bacteria, it is a fungus, or it is a parasite. In the end, they said that it is a bacteria, actually, which is very, very near to the fungus characteristics. So Mycoplasma pneumonae is a very small bacterium in the Plasmodium. Mycoplasma is the genus, is the human pathogen that causes the disease which is well known as the mycoplasmic pneumonia. A form of the atypical bacterial pneumonia. It is a commonly acquired pneumonia, although it is atypical. And this another important point is that it is related to the cold agglutinin disease, that is autoimmune hemolytic anemia. The Mycoplasma pneumonae is characterized by the absence of the peptidoglycan cell wall, and this wall resulting resistance to many antibacterial agents. The persistence of the Mycoplasma pneumonia infection even after treatment associated with its ability afterwards to mimic host cells, cell surface composition, and that is why it is immunogenic agent. After the so-called eradication of this mycoplasma, even then you find the antibodies and the immune reactions, atypical immune reactions in the body. Taxonomy and classification, that the term mycoplasma, myce means fungus and plasma meaning formation, is derived from the fungal-like growth of some mycoplasma species. The mycoplasmas were classified as mollicutes. Mollicutes means soft and cutis means the skin. In 1960, due to their small size and genome, the lack of the cell wall, this is an important point. Which bacteria lacking the cell wall? This is the MCQ. Low G plus C content and unusual nutritional needs. Its nutritional needs are far more unique than the other bacteria. Mycoplasma has also been designated as the arginine and arginine non-fermenting species. Mycoplasma are further classified by the sequence of the composition of 16 sRNA. All mycoplasmas of the Pneumonae group possess similar 16 sRNA variation unique to the group, of which the Mycoplasma pneumoniae has a 6.3 variation in the conserved regions that suggest the mycoplasmas formed by the degenerative evolution from the gram-positive eubacterial group that includes the bacilli, streptococci and lactobacilli. So indirectly their ancestors were the gram-positive bacteria. Mycoplasma pneumoniae is a member of the family Mycoplasmataceae, and the order is Mycoplasmatales. You do not, I think, need to remember, but only thing is that its unique thing is that it lacks the cell wall, and it is fungal-like, very near to the fungus, but it is not a fungus, it is a bacteria, and the ancestors of the during the evolution, they are deriving from the bacilli and streptococci and lactobacilli. And that is the summarization of my statement. Morphology, that mycoplasma are among the smallest self-replicating organisms and parasitic species that lack a cell wall and a periplasmic space. So they have got the characteristic features of the parasite also. Dependency on the host, it means. And cell wall is lacking and reduced genomes, peptidoglycan is missing, and they have limited metabolic activity. And that is why their survival is very, very prolonged. This is the pathogenicity which is described in this chart, how they are entering into the body and how they are attaching to the surface cells and their penetration and all of this and their products causing the inflammatory cycle, and it may be possibility it will also entering into the blood as bacteremia, as septicemia, as pyemia, and as what is known as the cysts and amodias, etc. The inflammatory pathway will be followed. The droplet infection, it is actually the way is to acquire the infection usually is a droplet, because the cough is there in these patients and they can transmit one person to the other person. So Mycoplasma pneumonia parasitizes the respiratory tract epithelium of the humans, and adherence to the respiratory epithelial cells is thought to occur via the attachment or gel formed, followed by the evasion of the host immune system by intercellular localization and adjustment of the cell membrane composition to mimic the host cell membrane. So the mutation occurs in the membrane of the cell means it is very, very near to the Mycoplasma cell wall. The composition, the antigenic composition, it is called the mimicry. They are same one. That is why they are inducing the autoimmunity in the body. Epidemiology, that incidence of the disease does not appear to be related to the season or geography. However, infection tends to occur more frequently during the summer and the fall months, when other respiratory pathogens are less prevalent. So this is the disease of the summer. The other type of pneumonias are seen in the what is called as the spring and in the winter seasons. Reinfection and epidemic cycling is thought to be a result of the P1 adjacent subtype variation. It is called the P1 adjacent subtype variation. Approximately 40% community-acquired pneumonias is due to the Mycoplasma infections, including, I mean, saying that in the overall the atypical pneumonias of the community acquired, 40% are thought to be causing by the Mycoplasma pneumonia, although they are misdiagnoses. And the children and the elderly individuals being the most susceptible. Again, the same one. The end stages, the peak stages of the life, the early life and the late life. However, no personal risk factors for acquiring the Mycoplasma pneumonia-induced pneumonia have been determined. That is, it may be related to the past history for tuberculosis or some other diseases of the lung. It is not related. The transmission of the Mycoplasma pneumonia can only occur through close contact. So it is a droplet infection. And by coughing due to the increased susceptibility of the cell wall lacking organism. And organism desiccation, outbreaks of the Mycoplasma pneumonia infections tend to occur within the groups of the people in close and a prolonged proximity, including the schools, institutions, military bases, household, and the camps, etc. Because everybody is very near to it. That's why the people, they get infection from one person to another person by droplet infection. The important point, one is it is atypical pneumonia, yes. It is not uncommon type of disease, yes. And third point is that it will induce immunity in the body and it may penetrate into the vascular system and it may be then afterwards what is called as a multifactorial, multisystemic disease. Now this question actually has been asked during FCPS Part 2 examination in the theory paper in, I'll say it is 1999. The clinical features is that the Mycoplasma pneumonia, first thing is primary atypical pneumonia. It may cause the tracheobronchitis. It may cause the upper respiratory disease. Now, primary atypical pneumonia is one of the most severe types of the manifestation, with tracheobronchitis being the most common symptom. Therefore, trachea is also involved. Even the children can have a stridor. It means that. So stridor can be observed in these patients. And because it is also involving the bronchi, it will also cause the wheezing in these patients. Symptomatic infections tend to develop over a period of several days, and manifestation of pneumonia can be confused with a number of other bacterial pathogens. Because the pneumonia is a pneumonia, you have to classify it into the community-acquired pneumonia and other pneumonias. I have already told you in my module which I have taken on the respiratory system, and the video is available. If somebody is interested to acquire knowledge, then they can follow the video. Most of the people who, specifically I will say the children should be admitted. Because you cannot do because there are risk factors or there old age patients should be admitted. Even the port score or the other scores of the pneumonia, they are not much, but the ages of the patients are important. The common mild symptoms include sore throat, non-specific wheezing, already said that, coughing, fever, headache, rhinitis, myalgia, and feelings of unease in which symptom intensity and duration can be limited by early treatment with antibiotics. Rarely the Mycoplasma pneumonia results in the death to the lesions and ulcerations of the epithelial lining, pulmonary edema. Another condition is bronchiolitis obliterans. That is, bronchiolitis obliterans can occur with this condition. The children are more prone to develop the bronchiolitis because, and they have to be admitted, otherwise the patient will not survive. Extrapulmonary symptoms such as autoimmune responses, central nervous system complications, and there will be dermatological disorders have been associated with the mycoplasma pneumonia infection in up to 25% of the cases. So the peripheral stigmata of the disease can be observed. And renal complications, the target is the renal one. And glomerulonephritis as well as a kidney injury secondary to the fulminant intravascular hemolysis, they are rare extrapulmonary manifestations of the mycoplasma pneumonia infection because this will cause the autoimmune hemolytic anemia, the cold antibody type, much RBC will be destroyed, and the load will be on the kidney, blocking the vascular system and causing the glomerulonephritis. The dermatological manifestations are two types. I already said that they are the peripheral stigma. The recognized causal relationship are the erythematous maculopapular or articular type of rashes and erythema multiforme. Both minor and the major form are seen. And Fox syndrome, which is a rare one, and a varicella-like skin eruptions. Zoster type of skin eruptions. Chickenpox-like skin eruptions. Not well recognized causal relationship or vasculitis, most frequently it is maybe associated with the Knox-Schondon purpura, and it can cause erythema nodosum in some patients. So these are the peripheral stigmata, dermatological peripheral stigmata. Now how you see here, this is the all erythematous type of the rashes, the red eyes, between the conjunctiva is involving here. You see here the difference of the blanching rashes, and the rashes are on the limbs, maculopapular type of rashes, tongues and the mucous membranes are involved. And very mimicking, it is causing what is called a Stevens-Johnson syndrome, erythema multiforme. But it is more than that. Severity of the disease is the Stevens-Johnson syndrome, but the mucosa is also involving ulcerations in the tongue and the mouth. And the Fox dystrophy is actually is a classification no longer ideal, but the stage 1, 2, 3 means the eye is involving. The cornea is involved like this infection. And there is, you can see that there is a asymptomatic common cornea guttate type of reaction, and there may be possibility of the morning blurring, strong edema around it in the cornea. It is the keratitis, you can say, and stage 3, more than a severity is there. It may be the symptomatic epithelial bully will be formed on the cornea. The vision definitely will be disturbed. And in the last stage is that the subepithelial fibrosis can occur and vascularization occur of the region. So this is called the Fox dystrophy. It is the ophthalmological manifestation. So it is the peripheral stigma again. Now here it is seen that erythema nodosum. It's painful, rash, it is a nodular eruption, painful. Although it is not very common, but it is the peripheral stigmata along with the pneumonia. And that is why it was asked in the FCPS examination. And in theory, hepatic manifestation also described has been associated with the cholestatic hepatitis in children, whereas in adults the Mycoplasma pneumonia infection usually occurs without liver involved. So liver is involved in the children, And a cholestatic type of the pattern is seen. Means the gamma GT will be raised, and again the alkaline phosphatase or more targeted enzymes which are raised. Recently, a hot discussion came up about the possibility of disease with the mycoplasma pneumonia in the adults also. The hot discussion, they do not accept that they are very, very common manifestation. Diagnosis should be done. Sputum examination, other than a blood CBC, you will find that in a blood CBC, possibility of the inflammatory markers are seen. That is the leukocytosis, and it may be the neutrophils are involved, and the neutrophil leukocytosis. And it is also seen with thrombocytosis. It is acute inflammatory response, that's all, not specific. The other examination, I said, it is a sputum examination. And a sputum examination can be done where you can do the sputum DR, and you can do, you have to also exclude the AFB in this sputum, and you can culture it, and you can see the pattern in the culture. Very, very, very specific culture characteristics are seen. It is a gold standard, although, but it is really practical possible tool. Rather, we are doing now the immunoblotting, immunofluorescence staining of the sputum or the other part of the body. The hemo absorption test, not available in Pakistan, and what is called the tetrazolium reduction, metabolic inhibition test. Serological assays, PCRs are used for diagnosis and characterization of the bacterial pneumonia infection. So PCR is the most rapid and effective way to determine the presence of the mycoplasma pneumoniae. However, the procedure does not indicate the activity or the viability of the cells present. PCR definitely is sensitive test, but may be false positive. Even coronavirus patient has also seen with this type of the positivity with mycoplasma pneumoniae, although it was a false positive. So that is the these are the investigation. You have to also do the X-ray test. It is a part of the routine examination. What you find in these cases, specific, there is no specific marker, radiological marker, but you will see the peribronchial and the perivascular interstitial infiltrates. Reticular densities, most common, around 49%, can be patchy with a segmental or non-segmental distribution. A part is involved, it means that part is involved. It may be possibility that it's just like a consolidation. That is 38% around. And the reticulo and nodular opacification occurs in 8% of cases. And nodular or the mask-like opacification are seen in about 5% of cases. This is a research work which has been done. The pattern definitely is not very, very pathognomic. A radiological marker is concerned, but suspicion will be there. If it is found nodular involvement seen here, there is a pattern of the consolidation, patch of consolidation. We find in this case the non-reticular type of infiltrations. You see the reticulonodular patterns, again the reticulonodular patterns in these areas. So these are not a specific one, although that's suspicious, because the pneumonia in most of the countries will deal like this, that possibility of the typical. If the typical is excluded, then go for the atypical. For the atypical, the topmost is in our country is the Legionnaires' disease, and then the Mycoplasma pneumoniae, and then tuberculous pneumonia. Other than that, the protease and other thing, the pseudomonas, etc. are also. So community acquired pneumonia is typical and atypical. So it is one of the commonest cause in the world as atypical pneumonia. Treatment. You have to give the antibiotics. Although the antibiotics we use here, nalidixic acid, or I mean to say quinolones and rifampicin, they are the very good antibiotic combination. I will give the moxifloxacin as a quinolones and rifampicin. But you can also use, in some cases, the combination of the macrolides or tetracycline or other ketolytes and the fluoroquinolones, combination of one or this one, or this one or this one, which may be administered orally. Possibility, but if the patient score, the pneumonia score is more, then you have to give the parenteral antibiotics. Otherwise, oral are enough. And they said that is the doxycycline aral weaks and shows interstitial permanent infiltrates on the chest X-rays. The doxycycline again is a very effective agent as oral therapy is concerned. They are bacteriostatic in nature, these antibiotics, most of them, because the penicillin groups and cephalosporin groups are not used and usually not effective. Erythromycin and clarithromycin, again they are the macrolides, they have got a very positive response. And other than the atypical type of the antibiotics can also be tried, which are not used. Polymyxin, trimethoprim, sulfonamides, or combination of sulfonamide with trimethoprim, cotrimoxazole, glycopeptides, and the beta-lactams. In some cases, only where culture has been done and sensitivity is positive for the beta-lactams. I already said the ancestors of the Mycoplasma are the cocci and bacilli, probably the gram-positive. And then they turn to the gram-negative, and then they mutated and in an evolution. And that is why in some of the cases only the cephalosporins and the penicillins are very, very effective, only in few cases. Otherwise the gold standard is this. You have to use the 1 quinolone and rifampicin or rifampicin. Prevention is that the vaccine for the Mycoplasma pneumonia and the prevention of the host cell attachment would prevent the initiation of the cytotoxicity and subsequent symptoms. Today, the vaccine targeted at the P1 adhesion have shown no reduction in the onset of infection, and some vaccine trials resulted in the worsened symptoms due to the immune system, because it will cause the cold agglutinin disease. The vaccines are dangerous to give in these patients. The vaccines are not commonly used, that is why. And in this fashion, again, the transmission can be cut off. You have to put the patient in the isolation or in the HDU or in the ICU with the corner it is blocked, and a strict vision should be given to the patient. And afterwards, even the patient was discharged because the patient has got now no fever, no complications are seen with as a pulmonary is concerned. But afterwards, the patient arrive with you after 1 week or 2 weeks with jaundice, because of now the autoimmunity plays its part, and the cold agglutinin disease will cause the hemolysis, and if it is a very massive hemolysis, then it can lead to the glomerular nephritis. So the ward should be separate for it. Atypical pneumonias, separation wards, specific wards. So this is the knowledge which I have want to provide. I should understand that every organism cannot be remembered by everybody, but I hope that this 30 minutes tutorial or a lecture, whatever we call this, may be beneficial of those who are appearing in the examination or those who are appearing as the aim to gain knowledge. And knowledge is power, and knowledge gives you confidence, and confidence will pull you to the very, successful physician or pulmonologist. I hope that you will try to understand that every bacteria should be, you should read, you should understand. So the infection and disease is a very important contribution in the internal medicine. That is why I am taking it is so much vast subject, and I think I have taken 22 lectures or more than that. Still there are 40 lectures that also have to be given to complete my infection and disease or infectiology. وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.